Hello, everybody. Dr. Chestnut here. It's been a while since I've done one of these updates, but my gosh, there's been so much information out, and I'm getting so many requests that I'm kind of, I guess, back online, so to speak. So I just want to go over some of this data from COVID to help people make sense of it. There's so much misinformation. There's so much anger and fear. There's so much politicalization of this. It's embarrassing. And so one of the most embarrassing things is the people screaming about how important it is to follow science, who wouldn't know good science if I hit them upside the head with it. And sometimes I feel like I'd like to. So listen, again, I'm just going to please call for calm, for respect, for kindness, and for logic and common sense when we apply science, and at least be honest. If you're not a scientist, please don't pretend you are and use that as some kind of virtue signaling or a way to I don't know, pretend you're something you're not. That's the worst thing. So let me go over some of the science. Again, I'm not pretending I'm smarter than anybody else. What I am going to tell you is that I do have a background. I have a master's degree in science, so I understand, the concepts of research methodology, what it means to establish a cause and effect relationship either between an intervention that prevents something or between a variable that causes something else. So I just want to bring some common sense and some real logic to this thing. So I've made a presentation because I think it's sometimes more helpful to show people some stats. But, I don't know how we're in a life and death debate over masks. First of all, if you actually look at the data on masks, it's equivocal. There's not a lot of evidence out there to suggest that a mask can stop the transmission of an infection. There's a lot of systematic reviews. I invite you to read them, and there's just not a lot of data to suggest that a mask can stop the spread of a respiratory infection. However, that doesn't mean to say that there isn't some evidence to say that it might stop the spread of some droplets. So, and what if it reduces the spread by a very small percentage that might not even be statistically significant? But what is the cost of wearing a mask? It's not a political cost. Yes, there's an environmental cost to these masks, but a lot of them, you don't have to get a disposable one. And so my point is this, is that to claim that we've got to follow the science and therefore, we have a study that shows that a mask can prevent the spread of some droplets or by 40%, and so therefore we know that it's going to reduce transmission by 40%, and therefore we know that if people wear masks, they're going to reduce 40% the death rate by 40%. Therefore, not wearing a mask is basically the equivalent of murder or not caring about your fellow citizens. None of those things are true. Any of the models about how many lives would be saved with masks or how many infections would be prevented with masks is a model based on a study which is not capable of establishing a cause and effect relationship between wearing a mask and reducing infection rate. Those studies have not been done. And in fact, the ones that have been done don't show a great result. However, that doesn't mean to say that it's not a reasonable approach to say, you know what, we don't have a lot of other things than washing hands and social distancing. So if you're going to be in close contact with people, why not wear a mask? Because in terms of the cost benefit, it just seems to make sense. Oh no. Anyway, I don't know what just happened there, but I had a thing on my computer saying it might not be working. So I'm going to keep going, and hopefully this worked. But anyway, something came up, said it might not be recording properly. So anyway, listen, I just want to go over some of the numbers so that we can understand. But I also just really want to encourage people to just because the science might not be perfect doesn't mean a conspiracy theory is any better. They're both ridiculous. When we're lying about science, it's no different than lying about a conspiracy theory. So let's do neither. Let's be kind and logical. Let's have this understanding that that the people in charge have to do something. They're doing the best they can. I'm sure in most instances, yes, there may be some corruption from big pharma and stuff. We all get that. But let's be honest, that if people did nothing, they'd be criticized. If they do too much, they get criticized. So all I'm asking is for honest communication and honest interpretation of the data, which I'm going to try and provide some. So let me split the screen here. And let me do it this way. And so let me just kind of go over some of the numbers. And really the only, as I said many times, what the questions that we have to ask are, is COVID-19 causing an increased number of deaths? So much greater than a bad flu year, that this is really an incredibly serious pandemic that we have to take these drastic measures of lockdown to address. And so that's possible. But I just want to look at it and I want to make some of this information more clear, because what we really have to do is we have to gather data as we go along and then respond to that data, rather than trying to stick to what we said from the beginning and trying to justify it. That's not science. So what we have to figure out is what are the variables that are causing these deaths? Is it people that are dying that would have died anyway, but they're dying with COVID? So therefore, COVID wasn't the causal factor that caused the death? Or are these people that have had pre-existing comorbidities for years and didn't die from the flu, and then when COVID-19 comes along, all of a sudden more people are dying? Even though they have comorbidities, they had these comorbidities and didn't die with the flu, but now they have these comorbidities and are dying with COVID-19, meaning COVID-19 plus comorbidities is more deadly than influenza plus comorbidities. So these are the questions we have to, and then we have to ask ourselves, what is the cost of the lockdown? Not just in terms of finances, but what do those financial costs mean in terms of social costs, in terms of addiction and deaths, kids not eating, kids not being able to go to school, more domestic abuse, more child abuse. These are real questions that we have to ask, because our response has a consequence, and we can't ignore that consequence. We have to be able to do a cost-benefit analysis of both the consequences of our response and the consequences of no response. And then we have to ask, when we look at that, is there a middle ground response? Is there a better response? So anyway, so let me just look at these things. And again, as I said all along, the best control group in this whole thing is Sweden, because Sweden didn't do a lockdown. They basically said, we're going to let this thing go through its normal sort of Farge curve. It's going to go up, and then people are going to get infected. More people get infected, the less it spreads, and therefore the less it spreads, the curve's going to go down, and we're going to kind of let that play out and see how it goes. So they didn't do a financial lockdown. They kept kids in school, other than some older kids for a while, but everyone's back in school. They're not having a big, huge spike. Their death rate is one of the lowest in the world right now. They're not, and so, we can't ignore Sweden. And this idea that we say, oh my gosh, we can't use Sweden's approach, because if we use Sweden's approach, there'd be millions of deaths, especially in the United States. Well, that's just not true, because as you can see on this thing you've got on the screen here, the deaths per million, there's only 8 deaths per million difference between Sweden and the USA as of yesterday. And by the end of the week, it'll be the same, or the US will surpass them. So the fact of the matter is, there's just really not that a big difference between the deaths per million in the United States versus Sweden, and I'm going to go over these numbers so you can see what the absolute number of deaths difference would be. And again, those are going to be caught up in a few days here. So anyway, let's just look at it. So in Sweden, they have a population of 10 million people. They've had a total of 5,808 deaths, and their deaths per million are 574. The U.S., obviously 30 times the population, or 33 times the population. They've had much more than that in terms of about, more than 30 times the deaths, but they're at 566 per million. So they're catching up. They're going to be there probably by the end of the week or next week. Canada has 37 million people. We've had 9,000 deaths. We have a very low death rate per million. Now, again, when you're looking at per million, if you made that per billion, it would be even less of a percentage when you look at it relatively. But if you make it per 1,000, that changes. So I'm going to show you all that stuff. But nonetheless, Canada's done a pretty darn good job. And what's the cost of that been? What has the cost of that been? We'll look at it. And could we have done a more targeted approach in terms of protecting the elderly? That's really important to look at. But nonetheless, I think those are the numbers. So now, if I go over here and I say, so let's look at the absolute differences. So the U.S. has 320 million more people. So if the difference in death rate is 8 per million, if the U.S. had the same death rate as Sweden, which is going to be by next week, there would be about 320 times 8, because there's 8 per million, 320 million more people. So there's 8 deaths per million times 320. So there'd be about 2,500 more deaths in the U.S. if they had the same death rate as Sweden. And by the way, there's 1,000 deaths a day in the U.S. right now, on average about. So in a couple of days, they've already made up that difference. So there's really no difference between those two approaches in terms of deaths. However, the difference in terms of, the consequences of this lockdown and, oh my gosh, the political unrest and all the other stuff is enormous. And that has to be looked at. Canada has 27 million more people than Sweden. We have a 333 per million lower death rate than Sweden. So therefore, there'd be about 27. If we had the same death rate as Sweden, we'd have to have 27 million people times 333 more people per million dying. So we'd have about 9,000 more deaths in Canada if we had the same death as Sweden. And that's pretty significant in my opinion. So that's those are interesting numbers to look at. So the next thing we look at is I want to look at sort of the differences. So again, we go 574 per million deaths in Sweden, 566 in the U.S., so 8 deaths less per million. Let's look at the percentage differences, because when you do things out of a million, it can distort the actual numbers of what we're actually looking at. So there's really an 8 per million difference in death rate between Sweden, who has had no lockdown, all their kids in schools, their businesses are open, no increase in depression, opioids, no increase in domestic abuse, none of these things that have occurred, okay? And the long-term consequences of lost jobs and everything. So keep that in mind. So it's about, when you do that as a 8 per million, which is a 0.000008, and then to get that as a percentage, you have to add 2 more zeros. So the U.S., for all of that they've spent, financial and social costs, has a 0.000008% lower death rate than Sweden, which, by the way, by next week, it will be higher. Okay, so, and also, right now, the U.S. has about 1,000 deaths a day. Sweden has, last time I looked, it was 1. Now, let's say it's going to go up to maybe 2 or 3 even, but right now they're at 1. All their kids are in school, and they got a death rate of 1. So right now, the U.S. has 100,000% greater death rate per day than Sweden does. Wow. Sweden versus Canada. Sweden has 574 deaths per million versus Canada 241. So there's 333 less deaths per million. So again, if we look at it as a percentage-wise, that's only a difference of 0.000003% lower death rate in Canada. And what did it cost us? Now again, though, that turns out to be, as we said before, that's about 9,000 deaths. So that's real. That's a big deal. Now, percentage-wise, it's not much, but we also have to look at absolute deaths. So I want to be fair when I'm going over this. But also, when we look now, Canada has about 16 deaths per day. Sweden has about 1 or 2. So that's a 800 to 1,600% greater death rate. And, our kids are we're not sure what we're going to do with our schools yet. Our financial debt is unbelievable. We've got the same social, problems going to go on with loss of jobs, and these things are real. And also, there was just an article in the paper in where I live in Victoria, and, in British Columbia, I think the average age of death from COVID is 87. So, not that that's not an important death or tragic, it is. But when you see that in terms of how to understand the statistics later, you'll know what I mean. But I'm certainly not trying to minimize the importance of the death of an elderly person in any way. So now, what did it cost? The questions are, what did it cost USA and Canada to get a benefit of 0.0001 and 0.0003% lower death rates? Actually, I should have updated that number because I've changed this since a few days ago, so it's even lower than that. But anyway, how much debt, how many overdoses and suicide, how much lost school time, how many kids aren't getting fed, you get it. So before we do a cost-benefit analysis of the lockdown response to COVID-19, we must know the benefits and costs of both the lockdown and no lockdown response, or an altered lockdown response. We must compare the cost of the lockdown response to the cost of what do we do versus Sweden is a simple way to do it, right? But we have to look at the cost of the response. We can't just look at the cost of COVID, and we can't make guesses about the cost of COVID based on models that were based, especially at the beginning, on infection mortality rates, but which were absolutely outrageously wrong. because we had done so little testing. So we were only testing people that were seriously ill, basically. So the number of people that were infected, right, was only based on the number of people who were seriously ill. But really, there was millions more that were infected that were not in that denominator. So the infection mortality rate was way overestimated. And everybody understands that now, I'm sure. But I was complaining about that before, everybody understood it, because again, data matters. So again, we need accurate data, which I've been talking about for ages. So again, even according to the CDC now, and everybody who's honest about it, which is almost everybody that I can tell so far about this stat, is that according to the CDC, despite enormous initial overestimates of infection rates, reported with hysteria, by the way, for months, the actual infection death rate for COVID is slightly worse than influenza. And as with influenza, the vast majority of deaths involve at least 2 other comorbidities, but that's also true of the flu. So we need accurate data on total deaths from COVID-19. This means we must accurately distinguish between a death from COVID-19 and a death with COVID-19. Is a patient who has terminal cancer, who gets COVID-19 and dies, is that a COVID-19 death? Is someone who has heart disease, serious heart disease, and has COVID-19 and they die, or respiratory illness, or, So in other words, what we're trying to ask is COVID-19 causing people to die that would have died anyway? Or is COVID-19 causing people to die that wouldn't have died anyway? Or is COVID-19 causing people who would have died in the next 6 months or year to die within a month or 3 months? Is COVID-19 causing early deaths? Is COVID-19 causing deaths that wouldn't have occurred otherwise? Or is COVID-19 really causing, being associated with deaths that may have occurred otherwise? And these things are, right now with our data, impossible to distinguish, because the only way to do this is going to be able to look at total mortality numbers over a period of several years. Now, right now, total mortality seems to be up about 10%. Remember, they talk about 180,000 COVID deaths, but remember, there's about 250,000 deaths a month in the United States that's a normal month. And so they're saying that there's about, let's just assume that the COVID-19 total, 180,000 deaths, that's an increase. That over the last, since January or whatever, or even February, March, that the last 6 to 8 months, that there's been an increase of 180,000 deaths over 6 months, or about 30,000 deaths a year. Well, that's about a 10% increase in total mortality. This is not unusual in a bad flu year. I'll talk to you a little bit about Sweden anyway. So the question will be, are those 10% increase in total mortality, is that 10% increase going to be offset by a 10% decrease in the next year or two? Because what COVID-19 doing is getting people who are at end of life to die early. They would have died next year, but now they're dying this year. So next year there'll be a lowered total mortality number. That may be the case. It's often has been in the past with bad flu years, but we don't know yet until we get total mortality data over several years. You can't look at total mortality for this year. You have to look at total mortality this year versus next year and the year after that, and then look at those number of years. So I hope everybody understands that. I'm going to spell it out in a minute. So there's been a great deal made of this CDC thing that came out that said, only 6% of deaths from COVID were COVID alone. And everyone said, look, only 94% of deaths weren't caused by COVID. COVID only caused 6% of all these deaths. That's nonsense. That's ridiculous. Listen carefully. Let's look at what we're trying to establish. We're trying to establish the variable that caused the death. So watch. Last year, all these people, these 94% of other people that died with COVID that people are trying to say didn't die from COVID. Well, those people had comorbidities last year. Half the population in the United States has comorbidities, which again is a huge issue, which we're going to have to discuss at some point, which I've discussed in earlier sort of videos. And I've said, the problem with the United States is that you've got the sickest population. You consume 60% of the world prescription drugs, which are also cause lack of can damage your immune response. You're one of the most obese, diabetic, heart disease-ridden, sedentary nations in the world. You've got massive amounts of your population that live in food deserts where they can't get healthy food. You can't tell them to go exercise and eat better because they don't have the option to do those things. You have a health system which is outrageously terrible compared to everybody else in the world. For most people, for some it's the best, but for the vast majority it's worse. And you spend double what everyone else does. So if that's offensive, I apologize. It's not political, has nothing to do with politics. I'm just saying there's a lot of variables that may be causing the United States to have such a huge death rate compared to other developed nations that isn't simply COVID. It might be your comorbidities, but nonetheless, you had the same number of comorbidities last year, meaning that the comorbidities can't be blamed as the variable that's causing an 10% increase in total mortality. That doesn't make any scientific sense. So all these people who are jumping on this thing saying, look, it's proof, see, COVID-19 is not causing it. I say, no, listen, I'm one of the people who say we've got to look at comorbidities. But let's not take this data and skew it and misrepresent it or misinterpret it, either through ignorance or malfeasance. The truth is that if we want to understand, we have to admit that all these people that have died this year with COVID-19 and comorbidities had the comorbidities last year. And they may probably, many of them, had comorbidities in the flu last year. So the fact is, the variable that's changed isn't the comorbidities. The variable that's changed is COVID. So now the question is COVID an additional flu? Did COVID come along and it's like a new flu, so we're going to have a flu season and a COVID season this year? And then, but the deaths that it causes are going to be in people who are very sick. And again, that's the case, right? Like the vast majority of people who get COVID-19 don't get ill, they don't go to the hospital, and they don't die. It's a very low infection mortality rate. So that what we have to wonder is, are these people dying early that are at their end of life? And the fact is, it appears that the vast majority of people who are dying from COVID are end of life, that they're very elderly and very sick. The vast majority, not all, but the vast majority, which is also true of flu season. So maybe what we should have done is taken better care of our elderly, instead of warehousing them and, all the mistakes that we've made. Anyway, something to think about. But I did want to go over these stats because we have to be honest about it, and a lot of people aren't being honest about it. So the only way to get accurate data on increase in total deaths is to compare total deaths in any given population over a several-year period. You can't just look at it 1 year. So, because we could say that total mortality increased this year, but if it goes down next year by the same amount, then it didn't change it. It just killed some people early that were at end of life anyway. So that's important to know because that's what flu does. Anytime we have a bad flu year, the next year we generally have a lowered total mortality rate. Look at Sweden. I'm going to show you the numbers in a minute. So, why does a bad flu year which results in higher total mortality numbers almost always result in fewer deaths the next year? It's because it kills people at end of life that were going to die in let's say it's 2020. So if you were going to die in 2021 because you're at end of life and you're very ill, but COVID comes along or the flu comes along and it causes you to die early. So you would have died in 3 months or 6 months. That would have put you into the next calendar year. But you died early because you're at end of life and very ill and very vulnerable, which is still tragic to lose a couple months, but just understand me. The next year, you don't die because you've died early. So the next year, that death that would have been on the books next year isn't on the books. It was on the book for 2020 instead of 2021. So 2020 goes up by 10%. 2021 often goes down by 10%. This has happened in 1996 and 2000 in Sweden. I always use Sweden because I'm just fascinated by it right now. But you can see that. You can go look that up in the literature. It's there. So anyway, I've just kind of explained that. So let's look at real world example. Again, use Sweden, the only real control group with COVID-19 strategy of lockdown because they didn't lock down. So more Swedes died. Most people don't know this, but more Swedes died per million per capita in 1993 and 1996 and 2000 from influenza over any given 1 month period than died from COVID in 2019 or 2020. So the highest death rate from COVID in Sweden this year did not match the highest death rate per capita from in 1993, 1996, and 2000 from the flu. And again, my next question is, did you also know that the increased total deaths in 93, 96, and 2000 were virtually matched with decreased total deaths the next year? Go look it up, and you'll see. So I just think that's important for everyone to know. Did you also know that in Sweden, as in most industrial democracies, both the overall population and the percentage of the population over 80 have both significantly increased? So each year, even if mortality rate stays the same, if your population goes up, your total number of deaths will go up the next year. Because if it's 10% of 300 million one year, it's 10% of 330 million the next year. So your total number of deaths goes up. But interestingly, also, the percentage of people who are over 80 is going up in Sweden enormously, but also everywhere else in the world. So that means now you have a higher percentage of your population, which is more likely to die. So your actual mortality rate, not just the total deaths, but the deaths per population, per capita, is probably going to go up a bit as your population gets older. So those are also things to think about when we're comparing, 10 or 20 years ago to today. By the way, it is always, sadly, the elderly that are most affected in terms of hospitalizations and death rates when it comes to seasonal respiratory illnesses such as flu and influenza-like illnesses, and of course COVID-19. This is not to say that these deaths don't matter. It is to say that they are not uncommon, that when it comes to influenza at least, they are expected, they are accepted, and they are not newsworthy. And that's important. We don't have a flu death counter. We don't interview people whose poor parents died, gasping for air from influenza-like illness that leads to pneumonia, which is what people die of with the flu. They don't die of the flu; they die of pneumonia, and it's not a pleasant death, but it's not newsworthy. And so, again, I just think it's important to just keep that in perspective. I'm not saying that this is no worse than the flu. That's not my point. My point is to say that we can't ignore what happens with the flu. We can't, and we have to somehow determine how. We know that COVID-19 has a very low infection mortality rate, but we have to know how to deal with it. We have to know whether or not this is a flu year that's added to a normal flu year. So do we have 2 flu years in 1 year? Or is this going to come every year and do this? We've got to figure it out. Because we do have a flu vaccine. It doesn't solve flu deaths. We know that. The flu vaccine does not decrease mortality from the flu. Look at the Cochrane review. Look at Jefferson's work and the Cochrane database reviews. I don't think that's even controversial. So nonetheless, but that's not to say COVID-19 won't do that, but the influenza one doesn't. So these are just important things to think about. So the questions being begged are, is the average total number of deaths from all causes going to be significantly higher due to COVID-19 over several year periods? So we've got to look, and we're going to have to compare the deaths from this year to last year, and they're probably going to go up, and then we've got to look at it again next year, and we're going to have to see. But most importantly, we're going to have to compare what happens in all these countries that are absolutely spending trillions of dollars on vaccines that have never been tested yet, given to companies that are convicted felons already of deliberately putting products out which they know were harmful and lied about. That's one of the things that frightens me. Every one of these companies that is getting contracts has already a convicted of deliberately lying, knowing that their products did harm and lying about it. So that makes me a little nervous. Anyway, and then we have to look at what's going on in Sweden. And we have to say, how is Sweden going to fare next year? If Sweden has another huge, big increase and they don't fare any better than anybody else, but no worse, that's something. What if they do worse? Then we know that's not a good approach. But if they do well, we can't ignore that approach. So anyway, and again, and Sweden didn't do a lockdown. They kept kids in school, never had an overwhelmed healthcare system, and it's seen the same FARS law. This is the curve, right? It goes up, people get infected, so it spreads less, and the curve goes down, both infection rates and death rates. So if we look at FARS law, and if you just look at that graph of total deaths in Sweden, right, you can see, right, that it goes, the slope is a lot more deaths per day. It's going up. There's a lot more deaths. And then as more and more people get infected, the number of new cases per day, or new deaths, per day, that's peak infection rate, it goes down. And so that's pretty common. And so that's total deaths. And we look at daily deaths. Here's what happens, right? Again, FARS law, it's the same curve. Just go back. Well, that's not the right way to plot that curve. But anyway, it's the same curve. So now if we look at daily deaths, what we see that in Sweden, right, without a lockdown, no vaccine in Sweden, no lockdown, no therapeutics, right, same as everybody else. And if what we look at is we see that it goes up, the infection starts to spread, more and more people get infected, the disease starts to spread less, right? Meanwhile, they stayed open, and then all of a sudden, the death rate goes down. So how do you explain the death rate going down so low in Sweden to it's like 1 or 2 to 5 a day now, really low, when they've done nothing? And then you say, yeah, but we can't afford that big curve up. Well, in the United States, you've had the same number of deaths per million people. So these claims that you're going to have millions and millions of people die just doesn't make any sense, because you're already at their death rate per million. So that doesn't make any sense either. So I think that's just at least important to look at. Next question is, what is the lockdown? Was it the lockdown that caused deaths and hospitalizations to drop in places, like New York and Italy, or was it the fact that it was just FARS law and the inspection for it? Because remember, Sweden had the same curve without the lockdown. So if two variables are the same, right, the curve, in the variable of the curve is the same in Sweden as it is in Italy, as it was in New York, but there was a lockdown in New York and Italy, but not a lockdown in Sweden, then how can you explain that it's the lockdown that changed the curve? That's just science 101. And so, maybe it's multivariable. I'm sure it is. Most things are, but but to simply say it was the lockdown that changed that curve doesn't make any sense if that curve changed in Sweden. So are the outbreaks in other locations going to be solved with lockdown? So let's just say, for instance, in the places that did do a lockdown, that now they get a second wave, a big wave. And so are you going to lock down again? And or how you going to handle that? Because repeated lockdowns are not sustainable. Everybody agrees to that. So are we going to have proper contact tracing? Are we going to have proper testing so that when people test positive that we can isolate them? Are we going to say, well, if there's an outbreak in a college or university or an elementary school, is that deadly? It hasn't been in Sweden, and it hasn't been in other countries that have opened up. So we say, well, they can take it home and spread it. That's true, but then shouldn't we then work on protecting the people who are vulnerable from these kids who may bring it home from school? Because the truth is, and I looked at this yesterday at the CDC data, that the number of deaths from COVID in people under 40 years old is less than a flu year. Under 40. Now it goes up in people over 40. There's no doubt about it. But under 40. So then my question is, should we not target who we protect and let these other kids go to school? That's an important question. I understand that you go, yeah, but if they get it and they spread it around, I understand that, but then maybe we need to protect other people and lock down, a target lockdown, rather than locking down the entire economy and keeping our kids out of school and people who can work from going to work. If you're vulnerable and you can't go to work, I understand. Let's help those people out. But I don't think we shut down our entire economy, and I don't think it was the right decision. Hindsight's 2020. I'm not saying I blame anybody. I'm just saying I think now we have enough data that we can maybe have a more targeted and a better approach, without being political and without hating each other and calling each other names. Are lockdowns only effective during the lockdowns? And if cases, hospitalizations, and deaths begin to rise, is that, again, I just talked about, is a lockdown and another lockdown reasonable? It's not. It's not sustainable. It's causing an awful lot of harm. We cannot ignore the harm, the increase in abuse, the hungry kids, the addictions, the loss of jobs, loss of future. It's devastating. And when we look at it compared to the infection mortality rate, I think we've got to be honest and have an honest cost-benefit analysis of that. That's all I'm asking. And anyway, only time will tell if Swedish approach was more successful. And it's going to be difficult to ascertain because Sweden's also had some of the problems from a bad economy because the rest of the world's shut down. So anyway, but we've got to look at it at least. I think it's fair to look at it. We can't just simply say Sweden's the for sure the answer, and let's just all do that, but we can't ignore Sweden either. Anyway, and we have to really look at, as I say, the economic, social, because what's happening is, these virtuous people are saying, follow science, which they don't know anything about science, but they're saying, we've got to keep on, lockdown, and that's the best option. It's the only option. We can't look at anything else. Well, most of these people can afford the lockdown. Most of these people aren't starving. Most of these people haven't lost their jobs. The people screaming the loudest are either getting enough government assistance that it covers them and they're comfortable, or they're not affected in the same way as the frontline workers and everybody else. And so the truth is, it's easy to be virtuous and tell everybody to lock down if your consequences are so much lower than the people who are saying we've got to have a different look at this. And again, we're all self-interested, but to pretend we're virtuous because we want to make everybody else lock down while we're not suffering the same consequences of that lockdown, that's not morally honest or intellectually honest either. So we have to look at it all, is my point. And I think we have to do it with some compassion, with real data and science, and some logic. And so I'm hoping that's what's going to happen. And again, Taiwan really did that contact tracing. I don't think we're going to do that in an open democracy, but it was pretty effective. Time will tell again, whether Sweden was right or wrong, or partially right or partially wrong. And again, Sweden's definitely more sustainable. We'll have to look at it. And I don't want to say there's no threat from COVID-19. Clearly, total mortality's up. Clearly, these people with comorbidities had comorbidities for the last years, and the death rate wasn't the same. So, come on. However, what we're trying to figure out is, are we summating 2 flu years together? And is we going to have immunity to COVID next year, like H1N1, right? Total panic. Vaccines that, had to get made that never got used, and the ones that, and there was problems with it. Same thing. A bunch of sleeper contracts went into play as soon as they announced it was a pandemic, and they changed the definition of pandemic for H1N1 from having to have death to just having to have infection, which is ridiculous. And then all these sleeper contracts went in. People made billions of dollars to make vaccines that never got used. So time will tell. And I don't blame anyone for being cautious and trying to do their best, but I just think we have to be honest about it. If you're not a scientist, please don't pretend you are. If you don't understand research methodology, and I just ask us to be reasonable and understand that the health authorities and the public, people that are in charge, they have to do their very best with what they have. And when I see things like the FDA changing policy without science and the CDC, that makes me nervous, because then they're going to lose the trust, like all the politicians already have. And then once they've lost their trust, which is their fault, then what? So anyway, yes, science is the answer, but only if it's science. It's the data, how you apply it, that makes a difference, and whether you understand it properly, and if the methodology's proper. So anyway, that's way too long. Thanks for listening, and I'll probably update soon. Bye.